women, we use a lot of accessories to improve sexual response, physical response, and to make things more comfortable for both themselves and their partner. And we have both Shelby and Melody and Maria in the back to act as a resource for this. In addition to all the medical and physiologic issues and psychosocial issues that we talk about, Melody is our insurance expert, if you will, and will be able to talk to you if you have any specific questions regarding how to maneuver in our office and what insurance companies pay and don't pay. It's a nice small group. We're lucky enough to have just a handful of people today, so it lends itself to interrupting, asking questions, and making sure that we're headed in the right direction. Very important to know that we're going to see a trend in medicine. We're going to see a trend in wellness. We're going to see a trend in multi-modalities or different kinds of treatment for sexual function. And very important to underscore that sexual function for men and women is really becoming an indicator of what your general health is. And so it is not a frivolous or an egotistical or a narcissistic issue to come to your doctor and talk about sexual function. It's not only an important quality of life issue, but it's a very important window into your general health, both from an emotional point of view and from a cardiovascular point of view. Some of the things that we look at, and we can categorize sexual function concerns. Some of the things that we look at clearly very commonly are hormone issues for men and women. We know this is we can think of what's going on in the media as a barometer of the importance of this. One, a lot of people are out there with complaints that are referable to low hormone levels. And two, there are a lot of things out there that afford appropriate treatment. It's also a barometer that when we turn on the TV or read the newspaper, there's all sorts of over-the-counter claims, if you will, to improve hormonal levels without the use of a doctor and without the use of FDA-approved medications. I caution you to be wary of that and be aware of that. And also, it's a good time. Last night we were interviewed by one of the local TV stations, because apparently there are a lot of Viagra type pills out there that are knockoffs, that are aftermarket manufacturers. Apparently last week our government identified a shipment from China that was laced with poison, rat poison. So it's a significant issue, it's a dangerous issue, and it's something that you don't want to screw around with. That being said, it's important to understand that in men, about a third of us over 40 years of age are going to have some hormonal issues. A third of us over 40 years of age are going to have low testosterone. Now, why is that important? Testosterone, everyone thinks about testosterone and muscle mass and virility and the desire or the libido and interest in sexual response and sexual energy. It's more than that. We can link cardiovascular disease with low testosterone levels. We can certainly link bone disease, osteoporosis, osteopenia, weakness of the bones to low testosterone. It's important because people who break their hip after about 65, 70 years of age have a 50% chance of dying. Half of the people over that age with a broken hip have a high rate of death for other reasons. It's not just the bone fracture itself, but if we can prevent that, that's a good thing. About a third of the people who come through these doors are here to have hormone replacement therapy, not for sexual function issues, but for a sense of wellness, to treat depression, certainly for bone strength, memory, mentation, physical activity, exercise, tolerance, all those kind of good things. And we're going to, and those are simple blood tests that we can utilize to determine whether people need hormone replacement, both men and women. In women, certainly after a certain age, or women who've had a hysterectomy and have their ovaries removed, or younger women in that 20 to 30 year age group who are utilizing birth control pills, their testosterone levels are low and they are at risk for all the negative things that guys over 40 are at risk for, including bone disease because of that lack of testosterone. Everyone hears about Viagra, Levitra, Cialis. Unfortunately, we're hearing a lot of noise about over-the-counter knockoffs as well. That underscores issues of blood flow problems, and Carol's going to speak to that in a moment. But when we have the need, when our bodies, men and women, and we use Viagra-type drugs in women as well, once they've been appropriately evaluated. If we have people that are utilizing Viagra-type drugs and all they're getting is a prescription for Viagra without a workup for what's really going on in their general heart health, it's a dangerous situation, because those people who actually need Viagra, men or women, to have an improved sexual response, may have an underlying condition that can lead to a heart attack or a stroke. Sexual function can be a red flag, or problems with sexual function can be a red flag for cardio and cerebrovascular disease. Real important. So everyone has the availability of these pills, whether they get them through their buddy or their neighbor or through the internet, or they go to a doctor that is not really offering them a good evaluation. Those people who are utilizing it may be missing an opportunity to treat the whole body, to treat the whole person, and prevent a heart attack and prevent a stroke. We know that there are program in sexual dysfunction has developed to a point where it's not only treatment, but it's rehabilitation. It's making things better for both men and women. We have the opportunity to use negative pressure devices to help make that tissue in the penis, the tissue in the clitoris, healthier by improving blood flow, by improving sexual function. For women, utilizing lubricants, utilizing different kinds of vibrators that can help stimulate blood flow. For men, utilizing vacuum tumescence devices, or devices that artificially dilate the vessels in the penis, improve oxygenation, and help in erections. 80% of the guys that come to our clinic are here in utilizing the vacuum devices not for sexual activity, but for rehab. Just like going to the gym. After a heart attack, what do? Once we're cleared to the doctor, we buy our new white tennis shoes, get a nice gym outfit, and we work out. That's improving heart health. We're improving penile health by doing the same kind of protocol. We're using exercises. So there are a lot of things that are available for us. How do we figure this out? Simple blood tests, an evaluation, a physical examination, a history, looking at what kind of medications you're on, what you've done before. Doing something called a Doppler test to look at blood flow to the penile shaft. Once we get that information, then we can determine the best kind of treatment, see if we need to get referrals, and we use referrals for our patient educators. We refer to Carol, who is our gateway into some great cardiovascular health and evaluation. We use sex therapists, both psychologists and sex therapists, to help with couples issues. So there are a lot of things that are available to us. In a moment, I want to introduce Carol, who will talk a little bit about what I've already touched upon and speak to in depth regarding cardiac health, if you will. But I want to make sure that we're on the right track here with everyone. Questions at all? Anything that I've said that piques your interest? Anything that I've said that piques your interest, by the way. Okay. All right. Yes?
I was really fascinated when you said women have testosterone. I never knew that. I thought men are the only ones that had just hormones.
You know, it's actually, we do a lot of lecturing at the undergraduate and graduate level, and most people don't understand. The question is that this young lady up in front is saying that she was unaware that testosterone is a female hormone issue as well. Men and women have testosterone. Men and women have estrogen. Men and women have estradiol and DHEA, and men and women have something called dopamine. All neurotransmitters, all hormones that are required at different levels for the different genders, but all required for appropriate sexual health. So yes, absolutely, it's something that we check and offer in both men and women. Carol, come on up here. I'd like to introduce Carol, who works with my cardiologist actually here in Fresno, to discuss some of the relationships between, I guess, heart health and hard health. I just thought of that. All right.
Well, as Dr. Schiff said, he and I work really closely together as far as referring patients back and forth between his office and ours. And the reason for that is because sexual dysfunction will actually precede coronary artery disease by about 5 years. If you've already started to identify that you have some vascular issues, your body doesn't say, I'm going to pick on one area and leave the rest of you alone. Usually if you have a vascular issue in one area, you usually will eventually exhibit vascular problems elsewhere. And of course, one of the major priorities is coronary artery disease. And if you think about it, the risk factors for coronary artery disease are many times the same risk factors that will manifest vascular issues that result in sexual dysfunction. Specifically, we call them the big five. Obviously, we can't control who we're related to, so family history is one of them. Smoking, tobacco dependency, very, very high risk for vascular issues. And we'll go into a little bit why that is in just a few minutes. Diabetes. We know diabetes affects vascular problems. Hypertension, high blood pressure. You go to the doctor and you say, well, I have high blood pressure. Why is that a concern? We'll talk about that. And then the last one is cholesterol issues. So out of those five, 4 are modifiable risk factors. All of those risk factors in some way damage what we call the intimal lining of vessels. High blood pressure, it's called the silent killer for a reason. When your blood pressure is high, the velocity of that blood going through those vessels is much higher. The shear force around those vessels damages the lining in those vessels and causes sometimes premature proliferation of the vessel and narrows them down. This is the same. High blood sugars, we know, affects, again, the intimal lining of the arteries. Same with cholesterol, same with tobacco dependency. All of those damage that lining. And if you think about it, in proportion, the vessels in the sexual area, in the penis especially, those vessels are very, very small. If you're going to have damage to vessels, it's going to exhibit a symptom much sooner than would your coronary arteries, because your coronary artery is a little bit bigger. So about 5 years or so, if you're having some vascular issues causing you sexual dysfunction, down the line, we're going to probably see you in our office and need to do a workup on you for cardiovascular disease as well. That's why it's so important, when we identify somebody has high blood pressure. We've got young guys who are in their 30s. They have high blood pressure. They go, why do I care? Well, again, as you get a little bit older, after many years of that blood pressure being so high, you've actually started to damage vessels. You've actually started to change the thickness and structure of your heart muscle. They begin to start having some sexual problems. And a lot of times, I'll tell you, I have guys that are hesitant to take blood pressure medication because they feel that it's going to cause sexual dysfunction. Yes, there are some medications that do that. But then I turn around and tell them, you don't treat your blood pressure, you will have sexual dysfunction for other reason. And it's because you've damaged that vascular bed. It's easy enough to do. to see if somebody has coronary artery disease or has a predisposition for such. You know, make sure your cholesterol is under control. It's easy enough to check your blood pressure. You know, if you smoke, don't. And diabetes, keeping your diabetes under control. Any questions about that specifically? You know, when Dr. Schiff identifies that there's a problem, he sends them to us. Okay, if you've got some sexual dysfunction, you may have coronary artery disease. Very easy to do. We do nuclear testing in our office. It's a test that specifically looks at blood supply to the heart muscle. It's an isotope that we inject. The study takes about 3 hours. We identify coronary artery disease a lot of times long before you even have symptoms. Again, easy enough to do. But if you already have some issues of sexual dysfunction and it is a vascular issue, chances are you have some coronary artery disease as well. And with those risk factors, you're also at risk for peripheral vascular disease, you know, stroke, carotid artery disease, and, you know, coronary artery disease. So it's pretty significant.
Carol, I'm in the medical literature, in the general internal medicine literature, you're seeing data on more women under 40 with silent coronary artery disease. Please comment on that and why you think that is. And also I'd like to get an idea of both men and women when you have people who come in with an initial cardiac event after they've been stabilized, and then you take their history. What percentage of that population is having sexual dysfunction issues?
You know, I think women tend to not identify sexual dysfunction as readily as do men. Do you not find that in your own practice? They don't really come forward with that.
It's a tougher history,
to
absolutely.
Right. And you know, we are seeing more women with early coronary artery disease. Our lifestyles are changing. They have the same risk factors as do men. We're seeing a lot of untreated high blood pressure and diabetes and cholesterol. And again, more women are smoking. I don't know that it was as prevalent in the past. There's more now. And you know, as Dr. Schiff said, you know, women, I don't know, we just tend not to say too much. You know, men, you know, you're not getting an erection. Men tend to see that. That's more of an obvious problem. Women, as we get a little bit older, obviously our estrogen starts to wane, and so there's problems with, you know, vaginal lubrication. That's not normal. Also, you know, there is also that vasculature that goes to the labia that is also so important during sexual function. A lot of the sensitivity is not there anymore. And women are at same risk, you know, as far as the hormone issues and the vascular issues. Same vascular issues occur, you know, or lack thereof in those areas as does men. Does that kind of address it, Dr. Schiff?
Yeah, I think that it's interesting. An impressively large percentage of both men and women walk through this clinic with a cardiac history or significant risk factors for a cardiac history that have not been identified. I'm curious at the other end when people come in for an elective evaluation for their cardiac history, and I know that you guys do a great job at screening for sexual dysfunction. What's your gut feeling on percentage of men and women who actually have had sexual dysfunction issues that once you query them?
Oh yeah, absolutely. I'd say probably 80% of all the people that I see, you know, and they've just had a stent placement. In other words, there was a blockage. We identified coronary artery disease. We put a stent in, and we'll be sitting there and we'll be talking, and I'll say, "All right, I'm going to ask you a personal question. Any sexual dysfunction?" And it's kind of like you see a sense of relief. Yeah, how did you know? Well, again, you know, if you have issues in your coronary arteries, you have issues elsewhere. And of course, Dr. Schiff gets a call. You know, we have to identify, is it a vascular issue? Is it a hormone issue? You know, he's the expert in that field, and we send him to Dr. Schiff, and they further evaluate that. So yes, I'd say about 80%. Absolutely. And it's always surprises me how that has gone unaddressed for so long, because as I said, it precedes us by at least 5 years. And people will say, well, you know, I'm 70. I've just figured, you know, I'm just getting older, and, you know, I'm just more tired. And the slowing down, I expected it to be a problem. Oh, not really. Shouldn't be. Shouldn't accept that.
And I'm just going to stand up here with you so they can mic me, but it's important to understand, and this is fascinating. I've been doing this for over 2 decades, and remarkable, I still have most of my hair. But when I used to lecture, and when 20 years ago, and when I would help train other non-urologists or people that weren't really didn't have a good understanding of sexual function, their answer to me was they don't have time. They have to think of more life-threatening issues like heart disease and diabetes. And we've really come full circle now because we understand the metabolic syndrome, all the complaints, an umbrella of complaints that Carol has just talked about, diabetes, high blood pressure, dyslipidemia, or high cholesterol levels. That is the red flag. And for people, it's really very cool because for people who come in and see us or hear about us because they have concerns of sexual function, hey, did you know that you have these risk factors for a heart attack or a stroke? And so we are not only addressing sexual function issues, which are very important issues and very personal issues for a lot of us, but we're also offering an opportunity for preventative medicine, for identifying a problem, preventing a potential catastrophe that can be addressed before an event. So that's a very cool issue, and over the last 20 years it's really come full circle. What I would like to do is have Homer come up here and just talk to us about his story. And a lot of us read about, recently the issues of heart disease or diabetes or high blood pressure or a heart attack causing a problem. There's also other things that can cause sexual function issues, and Homer has been great over the last couple of years, has really served as a patient advocate for all of us at the Department of Sexual Health in trying to get the word out. He's a great communicator and someone who can speak at a patient level because he is a patient and he's gone through this. I haven't gone through this. I've studied it, I've read about it, but I haven't experienced it. And we're lucky enough to have someone like Homer who is boots on the ground, if you will.
Well, my name is Homer, and I've been for the past 2 years patient educator. My problem was not heart problems or any other problem that Dr. Schiff said. My problem was that they found out that I had prostate cancer. So when they finally said that I had cancer, so they said that they have to take my prostate out. So I said, okay, well, I went through so many tests and all kind of stuff, so they finally said we need to do surgery. So I said, okay, but before I went to surgery, my doctor said, well, I already informed you what's going to happen to you after the surgery. And a few minutes before I go to this to the surgery room, he said, remember what I told you? I said, yeah, just make sure and wake me up. I want to be alive. So I really don't care if I will not be able to have any sex or anything, because in cancer, they told me that I had real bad cancer, and they was going to do the best they can. So fortunately that I kind of free cancer now, that everything is good. So after a year or so, 8 months or a year, my doctor said, well, we need to talk about your sex life. I said, what about? There's nothing there. He said, well, that's why we need to talk about it. I said, okay. So he said, we need to put you into Viagra. I said, well, I hear a lot of things about Viagra. I said, you know what? I really don't care about it. He said, let's try it. Okay. So I tried. Nothing worked. So I said, you know what? Nothing's working. So he said, well, let's try another thing. I said, well, okay. So then he said to use the vacuum device, which it was good. I like it. My wife kind of liked it. And then after 3 months, she said, you know what? I don't like it anymore. I said, why? So she gave me some excuses, and I said, well, okay. So I went back to see my doctor, and I said, you know what? My wife don't like it. And he said, well, I'm going to send you to see Dr. Schiff. I said, okay. And where's he at? He said, next door. I said, okay. It's in the same building. I went to see him, and he said, well, the last thing that we have that might help you is the pineal implant. I didn't know anything about it. I never heard about it. So I said, okay, you're my doctor. Go ahead and do whatever you think it's good for me. So since that day, everything went fine, and up to now, everything is great. My wife is happy. I'm happy. So we had a good life, and we're enjoying every time. So it's just something that's real wonderful, and that's how I become to be a part of a Dr. Schiff group. But for me to inform other persons about the things there's available for people who doesn't have an erection or have any heart problems or prostate cancer or stuff like that. And that's what I do, and I like to do it. And I come and see patients any day they call me. I'm here for them, and I like to inform them what is it and how it looks and everything. We had a model here that that I'm showing the patient what the implant it is. So that's part of my job here with when we had groups like this, and I'm very happy doing it because I know I'm helping other people. So that's practically what I do, and that's why I became involved in this, and I'm happy that I got the implant myself, and it's a real good thing. I learn a lot every day about it, and I inform the patients, and I'm sure that I had so many patients that I know that they called me and they said, you know what, I got the implant, everything's working fine. Well, just take care of yourself, and that's things like that. So that's my story.
Hold on, let me thank you for sharing that. But let me ask you this. I used to think that I was a great communicator, and then after listening to you over the years and hearing the responses from the patients that we had you connect with, it's very clear that you're offering a different kind of information than I'm able to offer as the physician. Tell me about your experiences when you talk to our patients, both patient and partner. What's the most common misconception that you're hearing about what we do at the department or what happens after an implant?
Well, I hear from patients after the surgery that they thought it wasn't going to work because they just think there's a piece of plastic inside of them. But like I told them, I said, well, you have to learn slowly so you can learn how to do it and don't rush anything. That's one of the things they want to do it right away. And I always tell them, you have to wait at least, 6 weeks or so. Mm-hmm. So there's a lot of misunderstanding about the implant, which that's what I'm trying to inform them the right way. We don't want to lie to them that they're going to have something that is not really true. So
what is it about your story that they enjoy hearing about?
Well, what they like about it is that I tell them that after they have the surgery done, then they're going to have a nice relationship between the wife and the husband, because there's going to be more communication, and they don't have to some of the husbands are afraid to start intercourse because they think they're not going to accomplish it. So that's one of the main things they ask. After they have the surgery, they seem like they're more open to talk about it, and they're more, both of them, they're getting more communication, and it seems like they're more happy. And that's really what happened. After you have the surgery, you get more things between both the wife and the husband, and they can discuss a lot of other things, because now there's more ways to do what it is as intercourse. So
we are lucky at Urology Associates to work with Dr. Leung, who is your robotic surgeon.
Yes.
And really, he's a guy that has tremendous experience and some great results. And what has occurred over my 25 years of urologic practice, it is very clear that we've gone from a preoccupation with prostate cancer treatment, and don't let me minimize the importance of that diagnosis and the intensity of the kind of treatments that patients go through, but we've become very good urologists at identifying prostate cancer and treating prostate cancer. Now, this is from the scientific model and the medical model. It's not an emotional position, but we know that for the most part we can identify and treat nicely, and we've been able to now not elevate ourselves, but change our concern, our energy towards quality of life issues. Now that we're doing a better job of treating cancer. When, as a patient, did you start worrying about the quality of life issue and the sexual function aspect of what you were going through, rather than being afraid that now you have cancer, what am I going to do? At one point, you felt more comfortable with what the doctor was doing, the robotic surgeon was doing, and then you became focused on, gee, what do I do about quality of life issues? What do I do about sexual function? When did that occur for you?
Well, that happened when my Dr. Leung said, we have to do something about your sex life. Actually, I was completely, that's it. He told me what's going to happen to me, and I said, okay, that's fine. I didn't want to die, so I said, do whatever you have to. And one of the things that I did is that I let him, Dr. Leung, do whatever he think it was better for me. Same thing when he recommended me Dr. Schiff about the implant. I didn't ask him anything because I didn't know anything about it. So I just, when he told me about the implant, I said, okay, go ahead and do it. I didn't ask anything. They didn't even show me the implant or nothing. I just went ahead and I let him do what he's supposed to do. When I wake up, everything was like nothing. And after maybe 4 or 5 weeks after the surgery, he started telling me to start exercise, how to inflate it and deflate it, and I feel like, wow, this is something nice. So after that, then he said, well, I think about 6 weeks later, he said, well, why don't you just start using it slowly? And I said, okay. So that was something nice, that I had a nice erection. And then my wife said, wow, what is this? So I said, this is what he did. So, but that's when we started having a nice quality of life, because everything came back. Everything just came back the way it was before. And I think now that I've talked to patients, they think just because it's an implant, they're not going to have the same feelings, the same sensation, that it's just going to be something like you're just gonna have an erection and that's it. But it's not like that. You will have everything, just like nothing you have in there. It's like you will have a good feeling, everything, just a normal person. So that's real good. I really enjoy it. So.
Well, this really underscores the value of having someone like your robotic surgeon who can really take a look at the total picture, and look at identifying and curing cancer, but also looking at the quality of life issues that surround that cure. And what we're finding more and more, and we're certainly promoting this in our department here, is that at the first onset of diagnosis, we start rehabilitation procedures immediately. Once someone is decided to be treated with their prostate cancer, whether it's a surgical procedure or radiation therapy or even watchful waiting protocols, which might be appropriate for a lot of patients as well, we're starting the rehabilitation aspect of sexual function. In 2012 medicine, you can't really separate that. It's great to have you up here. It gives us insight into what's going on from the patient point of view, which is important for me. I always find it a educational process. So I thank you very much, Homer. Questions?
I was wondering how much pain and discomfort do you have after the surgery? Is it significant or something that's just kind of bothers?
Well, this is something that even Dr. Schiff asked me once, and I'm not going to tell you there's no pain, but I really didn't have no pain at all. Since the time I left the hospital up to now, nothing, no pain. But I think what I did, that was the right thing to do. For some reason, I don't know who did, maybe Dr. Leon said, do not let the pain come to you because then you're going to have a hard time to get rid of the pain. So I think back then he told me to take the pill 1 hour before. It was every 4 hours, so I took the pill every 3 hours. So I didn't give a chance the pain to come back to me. And I didn't have no pain at all, not one single minute or anything. And I mean,
that's why he's our spokesman. The reality is, it can be a very uncomfortable situation if you're not following doctor's orders. We use things, we use different tricks to mitigate the pain postoperatively. Certain ice packs, scroll support, preemptive strike on the pain. You're not going to get addicted with the kind of pain medications we offer you for the short period of time. Utilize them. There's a reason they're there. It's important. There's no reason to tough it out. Right. Utilizing a small dose of medication for the short run for pain medication is absolutely important. And it's important not to fight it because it doesn't allow you to recover, doesn't allow you to stand up, doesn't allow you to walk and get back to your normal activity. So it's an important issue. If you don't follow the directions, it can be uncomfortable. Other questions? What I would like to do is I'm going to we'll cut the video now because I think he's charging me by the hour. But I want to get a chance to meet with you guys individually. We've got several staff here to answer your questions, to figure it out for you. We thank you for coming. We understand that it is Ash Wednesday, so I'm assuming all 4 of you are Jews. But thank you for coming, and we hope that you've learned something from this. We have all sorts of subspecialists running around here. I'll be happy to answer your questions, and thank you again.